everybody. John Kublank here with another exciting episode of Off the Cuff, all things healthcare. And every week, my week is just kind of bland. But then Wednesday comes around and I know that I get to see the great Arlene Maxim. And my whole day changes. I get so excited because I know that I'm about to learn something amazing this week that's going to help not only my agency, because I'm an administrator myself, but all of you people out there. And we have great guests today. So, Miss Arlene, how are you? How are you doing today?
Hey, I'm good, John. It's always an experience to find out how I'm going to be introduced on Wednesdays, but thank you so much. We do have some great guests today, and we're going to get a lot of good information today. So on our special guest today is Rory Farrand from Farrand. Did I pronounce that right, Rory?
Farrand? Second time, Farrand.
Farrand, okay, I'm so sorry. I should have checked on that before I introduced you. And Rory is from NHPCO, and I'm going to let her talk a little bit about her background and that type of thing. But our other guest today is Zaundra Ellis, and Zaundra has been on the podcast in the past, and she is one of my dear friends and colleagues from Axxess. And today we're going to, just to let you know, once a month we're going to focus our attention on Axxess technology. I have been in this business for a very, very long time. All of you know that already. And one of the issues I've always had in the industry is that I did not feel that there was a perfect software out there. Since I have been working with Axxess, I came on as a consultant 4 years ago. I got something on LinkedIn, so today was my 4-year anniversary. So 4 years ago, I came to Axxess, and I found that although nothing in the world is perfect, but I'm telling you what, Axxess has got the perfect people in the perfect places. You've heard that story about having the right people on the right bus. I'm telling you what, Axxess has that down. They've nailed it. So I am proud to continue to do consulting with them. They've got expert people in there negotiating the changes that need to be done. One of our most recent changes was to the Palliative program. And we have all been today was our deadline to get all of us in the Axxess program. That's talking about over 1,000 people right now in the Axxess company. Over 1,000 people now had to be certified by today in the palliative care program. So we all have that expertise that's necessary. And today we're going to talk about palliative. We're also going to talk, I saw Rory on a chat podcast a while back, and she was talking about how the guide program fit in so well with palliative care for dementia patients. All of you know that we have in the industry have a very hard time getting any kind of money for dementia type patients. So certainly if you have a dementia as a primary diagnosis on a home care claim, you're likely going to get audited on there. Probably the same thing with hospice. For a long time, hospice hospice allowed dementia to kind of skate through and didn't have a lot of attention paid to it. But now that's becoming something that's highlighted as far as audits are concerned and that kind of thing. So Rory, if you could just talk a little bit about your background and what you do at NHPCO. And then we're going to get into palliative care and the guide program.
Sounds good. So again, my name is Rory Farrand. By background, I am a geriatric nurse practitioner. I have a certificate in palliative care as an advanced practice registered nurse. And I've been in the industry since the late 90s. Interestingly, that we're talking about dementia, that's actually where I started my career. Clinically, was working in a geriatric population. I worked in assisted living facilities and oversaw memory care units for 5 years. And then when I became a nurse practitioner, I focused on work in long-term care and in SNFs because I happen to love that setting. I know some people find that strange, but it was really, where my heart is. Excuse me. So I've been working both as a clinician, but as an operator for going on 15 years now. I've worked in a number of organizations that specialized in home-based care. One of the ones that a lot of people may have heard of was I worked at Aspire early on. I was there for several years as it grew and scaled before it sailed to Anthem. And I spent some time at VITAS overseeing the palliative care division. So at NHPCO, I'm the vice president of palliative and advanced care. And my responsibilities ultimately are supporting our members. NHPCO is a membership organization for folks who don't know. and it's been around just about as long as the hospice benefit has been around. It was founded in 1978, which is when the Medicare hospice demo was actually launched. So it's been one of the strongest vehicles for advocacy and policy change related to the hospice benefit, as well as to palliative care programs and things like that. So as it pertains to palliative care clinicians, the majority of palliative care in this country is delivered by hospice organizations. So I support our members by providing education and resources. I also support the policy and advocacy team related to initiatives around palliative care. So that was kind of me in a nutshell.
Okay.
Awesome. Thank you.
Zaundra, if you just briefly want to talk about yourself in case the folks on today have not heard you introduce yourself. Could you just talk about a little bit about what you do?
Sure, Arlene. Thanks, Rory. You don't know this, but I went to school. My degree is in long-term care administration, and I worked as a nursing home administrator for years. I love that setting too.
You get it.
I get it. So, but now I work in hospice. I worked in hospice for over 20 years as an operator. When I started, I really had a passion for quality and compliance, and patient satisfaction, which worked out really well because sometimes there's not a lot of time to spend on that, right? So I've done that for many years. I've been at Axxess for 6 years. I'm the vice president of hospice professional services. So not only do I represent Axxess in the community, I also am responsible for creating training and certification content for our training and certification platform, as well as our own internal compliance. Arlene and I work on that together. So I'm delighted to be here today.
Thank you so much.
Mm-hmm.
And Rory, just as you were talking about NHPCO, we've all heard that there's a potential, or it's actually happening, a merger between NHPCO and the National Association for Home Care, and that's going on. Is that correct?
That is correct. The letters of agreement are theoretically going to be signed this month sometime. I think all the documentation is ready. They just need to get the ink to paper. But it has been, I think it's a really exciting opportunity for our field. For folks who are familiar with both NHPCO as well as with NAC, we really represent the entire continuum of care at home. So this is a huge opportunity for two very strong policy and advocacy organizations to come together to support all of the care that's delivered in the home-based setting across the continuum. So I'm really excited to sort of see what's going to happen with that. It shouldn't be a surprise. I mean, NHPCO and NAC, as well as NHPCO and other organizations, often collaborate on particularly policy and advocacy issues. And so I think this is an opportunity for our two organizations to basically come up with a really strong, unified, and very intentional organization that's going to benefit everybody who works in the home-based space, for folks who have serious illness and end-of-life care, of course.
Don't you think it's going to help us too? I know that, sometimes the post-acute care businesses kind of get pushed to the side because nursing homes and hospitals and pharmaceutical companies, we can't forget them in healthcare, have such strong lobbying groups. And I think that this merger could really help us. Do you agree with that?
100%.
And lobbying?
Yeah, 100%. We have a very strong policy team at NHPCO and a wonderful group of colleagues over at NAC. So I'm really excited to see how together with unified front is really going to impact and sort of move things forward in Congress. So there's a lot of changes that need to happen. I'm sure folks are aware that there's a lot of scrutiny on hospice these days. Not necessarily unwarranted, but not also all fair either. So, what we do this work, we know what's going on in the field. So I think we have the opportunity to really educate folks on the Hill about what's going on. Every time I've been at a Hill office, it honestly floors me how little people know about end-of-life care. They don't understand what palliative care is. They don't know the difference between palliative and hospice. And so we spend a lot of time doing a lot of education to lawmakers. And so I think it's an exciting opportunity and really eager to see what comes out of it in the next couple of months.
Was there any key points or key topics that both organizations felt or is ready to start to come together and take charge on right away?
Yeah, the special focus program is probably the biggest one right now. We all believe that the algorithm is faulty, and that the way that they are, the intention is good. We don't want to get to mislead anyone and say that we don't believe that there should be increased focus, especially on organizations that perhaps are not good actors. Folks who are coming into the delivery of hospice care for inappropriate reasons, not sort of mission-driven folks. But the algorithm is not really going to end up targeting those poor performers, low quality hospices, or those folks who might be engaged in fraud. So we really are pushing CMS to try to take a look at that algorithm, to revamp it, and perhaps develop a different model that will actually target those low quality providers. The other thing is in response to a recent request for information from CMS about VBID, the value-based insurance design model, especially the hospice benefit component. There are some changes that are going to be rolling out in the next couple of years related to VBID, and they've asked everybody for feedback on that. One of the things that we all feel strongly about is not having prior authorization requirements for hospice. Every time I even mention it, it kind of makes my stomach turn over because it's so stressful to think about. So there's, things like that. And we come together, whether the four sort of hospice and home care organizations, or we also partner with the National Coalition for Hospice and Palliative Care on a number of other initiatives. So
yeah,
those are kind of the big ones. Yeah.
That's great. So we're talking about, specifically, we wanted to talk a little bit about the guide program that CMS has rolled out with. And unfortunately, the deadline for signing up was yesterday, I believe. But as we were talking before, if this does well, this probably is going to reopen at some point. But can you give us kind of an overview of what the guide program is?
Yeah, GUIDE is an acronym that stands for, now I got to look it up.
I think I have it right here. Hold on.
It's guiding something, the dementia experience. But
guiding an improved dementia experience. Yes.
Yeah. So what's really exciting about this model is that when you read it, if you are well versed in what palliative care is, I was actually surprised that it didn't come right out and say this is a palliative care delivery model, because it is a very holistic wraparound approach to both the patients who are experiencing a diagnosis of dementia, as well as for their caregivers. So I think one of the most exciting things about it is that it is one of the first models that really recognizes the stress and strain that the majority of caregivers in this country who are caring for folks with dementia experience.
Yeah, so, and I think it's the caregiver side is so overlooked in most of these areas, especially in dementia. You're right.
Yeah, and you mentioned too that there's a lot of scrutiny on the nursing home side of things, Zaundra. You're probably very familiar with that. One of the goals of this model is to support patients and to help their caregivers keep them in the home setting. The majority of people, when you ask them, would much rather age in place. But a lot of times, given the complexity of an illness like dementia, it's really hard for folks to be able to do that. So ideally, this model is going to test out with some additional supports, with some dollars allocated for respite in particular, which is something that you can't get in other settings outside of hospice. So these folks will be able to have the opportunity to, on an annual basis, there's a certain dollar amount allocated for respite care, which caregivers really need, at some point as folks, advance through the illness and there is more behavioral and psychological complications of that. Folks really just need a mental health break. So it's really wonderful that that's going to be built into the model.
And I think too that the training of the caregivers, Zaundra, you have been involved in training and certification in the Axxess company. And I know that we are getting ready, or Axxess is getting ready to roll out a caregiver training, which I think is going to be exceptional, where caregivers will actually be able to get online and get training. Do you have any additional information about that?
So yeah, Arlene, I think our training and certification, is continuing to grow. And I wanted to take a step back, and I really love what Rory said about keeping patients at home. Yeah. Right, dementia patients at home, because not only is that transition to a skilled facility, whether it's assisted living or nursing facility, really tough on the patient and family, what we know is that 90% of patients who live in residents in a nursing home don't ever get a visitor. right? And so that's tough, right? And if we can avoid that and keep folks at home, they will be so much better for it. So, training and certification just keeps growing and evolving, right? There's something new to add all the time. But yeah, we are going to do some caregiver training, make that available to caregivers. And, we will likely have a guide section for that, right? So if we have providers that partner with us, they'll have access to that training so that they can leverage it to use for their family as part of the model participation.
Rory, what do you see as a future for like seniors with dementia? There are statistics out there that are pretty staggering about the number of dementia patients that we will see over the next number of years.
I'll actually quote those. I pulled them up because I think they're really important. So as of 2023, dementia afflicts about 6.7 million Americans, and that number is projected to grow to 14 million by 2060. So that is a huge number of folks that are going to be affected by it. Obviously, the incidences of dementia increase with age. 1 in 9 folks, so that's about 10% of people age 65 and older, have a diagnosis of Alzheimer's type dementia. Alzheimer's is one of those unusual illnesses that you can see it in younger populations, but that's a lot less common. Yeah. And 1 in 3 seniors dies with a diagnosis of Alzheimer's or another type of dementia. Over the last 20 years, deaths from Alzheimer's in particular have increased 145%. So part of the reason it's really important to talk about this is because dementia in and of itself is an umbrella term. It's a syndrome. The term, a diagnosis of dementia is more of a, sort of a global category, because dementia is really just a collection of symptoms that primarily relate to cognitive decline. A lot of people understand that there's memory aspects to it, but it's an illness that also includes behavioral components. Folks can experience profound psychological symptoms. And the challenge is, again, this is an illness that impacts people primarily as they age. As people age, they tend to have increased other chronic illnesses and sometimes multiple chronic conditions. And because of that, their care is really fragmented. It's kind of like a popcorn approach. They may see their cardiologist, they see their neurologist, they see their nephrologist. And so what ends up happening is that there's no real quarterback, no real driver of what's going on with that person's care. And what ends up happening is that, people are on a ton of different medications that can cause complications in and of itself. So we see a lot of patients as they age that have high levels of hospitalizations. They get their care through the emergency department. And sometimes the drivers of those visits are those behavioral health symptoms that I mentioned, agitation and aggression, things that are really, really disruptive, particularly to caregivers and for those folks who live in community settings, whether it's an assisted living or a nursing facility. That's incredibly disruptive, not just to the community, but to those caregivers. That's probably the primary driver that folks end up in nursing facilities, is because they need that management of those behavioral health symptoms. So it's really difficult. And of course, those are the kinds of things that stress out caregivers. We're talking a lot of times about families, but many times friends as well. 25% of folks who have dementia live alone in the community, so they don't have somebody who lives with them, and maybe they rely on the good graces of neighbors or other members in their community. So you just think about all of the things that goes along with managing an individual's health care, providing constant support, reinforcement, taking care of personal care needs, dealing with all of those symptoms. That puts a huge strain on those caregivers. And then they themselves end up with increases in psychological stress and strain, emotional challenges, as well as financial issues. And to close the whole conversation around that, this is an illness that also disproportionately affects Black, Hispanic, Asian Americans, Native Hawaiian, and Pacific Islander populations. So we already know that this is a community that is historically underserved for a variety of reasons. And now we are seeing, this very devastating illness on top of it. So it's a real sort of endemic kind of problem that we have with this illness in our country.
Absolutely. When
John,
you talk about, sorry, go for it.
No. I didn't mean to interrupt you.
I think you had said it, Rory. It's the unpaid caregivers, right? And in our industry in hospice, I have families that are signing up to do that provider service and these sort of things, and every little bit counts. But I think this is a really good, and you said in the beginning, a really good direction for us to be heading in, where we're partnering both with the family unit and the patient together, and in a way incentivizing better results instead of costing and being more of a harm. Because you look at Medicaid or non-state provided provider care, it's so expensive, especially when you add on behaviors, right? Because if you're a medical professional, you're like, oh, well, does this person hit or bite or yell or scream or throw stuff? And with dementia, sometimes we don't have the option to decide what their disease progress is going to present, right? So I think it's awesome. And is there other ways that we should be expanding that involvement of the family?
I think in general, we really should, and this is what I've always loved about nursing, is that nursing considers the family the unit of care. In contrast to a medical model, which the patient has X disease, which inflicts X system, and it's kind of this sort of very narrow focus. Nursing as a holistic approach to care always kind of looks at, well, not just does this person have this illness, but how does it impact their lives and in what way? And to sort of take that a step further, how does that impact the family unit? So I think that nursing has always kind of taken on that approach, but I think that it's not just conditions like dementia that impact the family caregivers. Any advanced illness where the person's functional status changes and they're relying a lot on others for support is going to be a burden. And I don't like to use that word because it's so negative, but on those caregivers. I mean, it is what it is. It is a burden. Many people do it out of love, and they do it and they would never complain about it, but it does create additional stress and strain on those folks. And think too about those individuals, 25%, like I said, of folks with dementia live alone. So now you've got these lovely neighbors you might have had for 20 years, and they themselves are elderly or frail, and they're just checking on you because they're good people. That's additional stress and strain on them as well. So I really think that our healthcare system really needs to address the needs of caregivers, and we're seeing more and more attention to it, for sure. The National Academies had a workshop a couple of years ago on caregivers. There are organizations out there that are designed to support caregivers across a variety of ways. Archangels, for example, has a distress thermometer that you can look at, and it'll tell you like almost using like a stoplight model, red, yellow, green, where you are in terms of how stressed you are, and whether or not you need to take a look at what's going on, which I think is very novel. Because like anything else, it's like that analogy of, you putting a frog in a boiling water. When, if you start out with the cold water and you just turn it up, you never notice that it's increasing. And I think that's what a lot of caregivers experience. They start out with thinking this is just normal. And then 2 years later, they don't realize how much more they've taken on and how much it's affected them. So I think it would behoove us in general, unless we start paying for these caregivers to take care of folks, we really need to build into our care models ways to address what they've got going on.
I think unless you've experienced it, and Rory, I know you and I talked earlier about how we've both experienced this in our own families. And, my father actually, I believe that his expiration was much earlier than it should have been, because he was my mom's caregiver. We all, and he would not tell us a lot about what was going on in the home. Once he started having health problems, then we were able to discover that there was more going on in there than we were ever told. But I think that the lack of understanding of how this all works and the need for these people to have some relief. I mean, when you talked about the respite care, that's just so important, because that respite experience for the caregiver could be a matter of life and death for them. My mom actually ended up getting kind of mean at the end. And it wasn't, I'm sure it was, it was because of her disease process. It wasn't because of anything intentional, but it was just part of that. And that was hard to deal with, very hard. Until
generational component too, to folks not wanting to admit that they're struggling. As the generations of are changing over, probably from, your parents' generation even to mine. my parents, they're much more willing to say, I need support, I need help. And I think that obviously younger generations are getting even more open about talking about mental health issues. There's not as much of a stigma, but I think some people, they've just grown up with that expectation. We don't talk about this, we keep it within the family. And there's no shame in reaching out to say, hey, I need some help, I need some support. And when, when we find folks that are struggling, I think if we can provide them practical support, like, let me pre-cook a couple of meals for you this week. Let me just, give you stuff that you can put in your freezer. That's one less thing you have to worry about. Or let me take so-and-so to the physician's appointment. Little things that we can do to just give that person maybe an hour or two of extra time where they can kind of decompress makes a huge difference in how they're feeling about being able to continue on with that care.
How is CMS or what should CMS be measuring or watching for measurements of success with this program? And what are some things from your own experience that would show signs of success in a program like this?
I think one thing that they're definitely looking to test with the guide model is reduction in nursing home placement. So if you think that a lot of people end up there, probably not because they're that they need physical rehab or anything like that. They're there because somebody can't take care of them in the home anymore. And it's generally because of behavioral interventions. So I would love to see, obviously, that number go down, but I would hope that by allowing people to age in place, there may be less reliance on psychotropic medications that are generally provided off-label to manage behavioral symptoms, antipsychotics in particular, which is already a quality measure in nursing home care anyway. But if we can, help people reduce reliance on that as a chemical restraint for, to preclude behaviors, I think that would be a really important piece to look at. I also think that if you are taking care of folks in the home, you're not, messing with their environment, there may be lower incidences of delirium. Delirium is really dangerous in patients who have dementia because if you have a delirium episode, there tends to be an increased risk for mortality. So if we know changes in environment, hospitalizations in particular, basically can cause a delirium, for a variety of reasons, whether it's because of illness or just change of setting. So I think those would be a couple of the key things to take a look at. Again, the education component for those caregivers, making environments more safe. So maybe that person has less risk of falling or injury from a fall. And the care coordination piece, I would expect to see a reduction in overall polypharmacy to those patients. And I think that, again, is another key clinical measure that would be really important to check, because not somebody driving that care across the continuum, they can say, well, we don't need 3 anticholinergic medications right now. So, they can look and try to streamline those and make sure that the person is taking only what they need and not what they don't.
Medication management, I believe, if I'm correct, is, a cause of almost 50% of hospital readmissions in some way or another. Management, interaction, not taking the meds that were prescribed, like so many things. And then you add on dementia, you add on stress. A lot of times it just feels, again, even from an outsider, just overwhelming.
It is overwhelming and it's expensive. If you're the increase in polypharmacy is not, the risk from polypharmacy is relatively with a low number of medications, 5. You start to seeing almost 100% guarantee of interactions of medications. Mm-hmm. Majority of patients I've seen, 5 is like a laughable number. I've had patients who had 22 medications. I've had patients with 40 medications. The amount of time that they spend just like figuring out when to take them. You spend all day swallowing pills. So that's untenable and it's ridiculous. And likely you end up with these prescribing cascades. This medication gives you nausea, so you throw on this medication to deal with the nausea. That causes constipation, so now you add a third one in for that. And then, it goes and goes. Rather than having somebody who just sort of takes a look at the entire picture and says, do we actually need this? And so many medications are just not discontinued, not because of malice, they just forget. They're really, especially dementia medications, surprisingly, if there isn't a demonstrable improvement and maintenance of sort of those skill improvements, it should be discontinued. But families don't want to discontinue them a lot of times because they feel like, well, at least I'm doing something. Aricept or, Memantine or, any of even the newer ones to some extent, if they don't work, they should be stopped. And, but that's the only sort of hope that sometimes families can hang on to, because they know this is an insidious, progressive illness, and they feel like at least I'm doing something. So I'm excited about the educational components in the guide model. I love that Axxess is working on a caregiver module. I think a lot of education is so important. If you know what to expect and you know that this is a normal thing that's going to happen, then I think a lot of people are less freaked out by things when they do happen, and they're more prepared for, oh, okay, this is an intervention I can actually deploy, and it doesn't necessarily have to be pharmacologic.
Yeah. And John, I love what you said about the medications, because that is the key component of the guide model's quality measurements, right? So, also really thinking about, that caregiver assessment. They're going to be looking at that data to make sure that you are assessing the family unit, right? And I think it's, really interesting. There's a socioeconomic component of the quality measures as well. And so what's really interesting is that piece actually, so quality overall affects your reimbursement, right? So they can take as much as 3% back, or they can add 10% more depending on your quality scores. But there's also an incentive to make sure that you're serving the community where you operate, right? And so there's an additional adjustment that goes along with kind of a socioeconomic assessment of the patient, right? So you can, it's not a set amount. You're going to get, X amount of dollars all the time, right? It really kind of is a venture into home care that is reimbursed based on quality, right? Outside of home health. And so I think everyone should pay attention to it, because we're going to continue to see this type of reimbursement grow.
Well, and I remember with telehealth a few years ago in 2017, 2016, I think Texas was one of the first states to carve out a telehealth program that's under the home health program, but it's not billed under home health, which reminds me of this guide program. And especially in the home health industry with, reimbursement always being what seemingly cut or reduced. Operators and owners and communities have to look for programs or hope for programs like these to start to connect and tie the dots in these places where we don't even have the opportunity to expand our care. We're stretched as it is.
Well, the other thing I think that's unique about the guide model, it's the first time I've seen it presented like this, is that your organization does not have to be the entire provider of all of the things that CMS is going to be looking for in the model. So perhaps you have 80% of what they're looking for, but you need a partner to provide respite.
Right.
You can partner together to create sort of a CBO, and together apply to be in the model, and therefore you can all figure out how you're going to divvy up the payment, but that you don't have to be a one-stop shop. And I think that also then encourages partnerships within the community. So community-based organizations are where so many local hospices operate anyway. They know who the good partners are. They know who delivers what and who does this, that, and the other thing. So I think it's really wonderful that it's encouraging those partnerships. Of course, there's going to be some of those unicorns that have everything. But, as with any CMMI demo, there are significant technological requirements that they want you to have. And, I know Axxess happens to be one of the software providers that actually meet those qualifications to be able to deliver both the security and the type of data fields that the demos require. The EMRs, I think, are going to be a big burden for a lot of folks to entry into any demo, because they correct me if I'm wrong, Zaundra, it's like ONC and certification. And I honestly couldn't tell you what those acronyms mean, but I know that a lot of EMR, EHR companies don't have that. They're moving towards that. But, Axxess was one of the earlier ones that achieved that for the palliative and hospice softwares, which I think is really important, because that's going to be a huge player with people who want to participate in these alternative payment models in the future.
What's happening to the dementia patients now, Rory, with maybe this, I'm maybe talking backwards, but where are these dementia patients going now? They're not. Is that correct? They're just there, and there really isn't any mechanism for us to care for them other than private pay, or these organizations that take them on and then have to go through the audits that they go through.
So I think there isn't a particular palliative care delivery model for dementia in particular. Palliative care in general is a good approach because it's a holistic, service. It looks at all the aspects that, make up a person and their family. And we do a really good assessment. We do, individualized care plans. We work really hard to incorporate the family into all of those different kinds of things. But right now, I think the majority of dementia patients, as I mentioned, probably are being cared for by another model. Maybe they have heart failure, they have cancer, maybe they have renal disease. And so they're kind of falling into those buckets. And then dementia is a secondary diagnosis. The problem I have with hospice and dementia is that when you think about a cancer patient who is admitted to hospice, they are relatively functional at the time they're admitted. They're able to walk, talk, participate in their care planning, and it looks they sort of appear in a certain way. The eligibility criteria for hospice for dementia is much more different. This is for Alzheimer's, we should be using the FAST scale, the functional assessment staging tool, and that's approved only for Alzheimer's, but people kind of use it for everything. But the eligibility is when the patient is at a level 7, and in particular, level 7C, which, to put a visual to it, is a patient who is bedbound, incontinent in bladder, who has 5 or less meaningful words. That looks very different. That person's experience of the hospice benefit is going to look very different than that walking, talking, able to engage in programs of the cancer patient or heart failure or other types of patients. So by the time a dementia patient is eligible for hospice, a lot of the benefits that we provide as hospice, and palliative care providers has kind of passed, not to say that provide support and things like that, but it's a really different experience for those patients. And so I think that at some point the model needs to change to allow more upstream palliative care, perhaps under the hospice benefit, perhaps under some other thing that allows that support for the patient and the caregiver when they can actually benefit from it. Because by the time they're a 7C, it's really challenging. You mentioned audits, and that's the other thing that causes a lot of heartburn for hospice providers in particular. The audits that happen at the 180th day after their, I think, 3rd certification period, because they didn't die in a timely fashion. There is no predictable trajectory for a dementia end-of-life course. If somebody has acute unexpected illnesses, they develop sepsis or they have pneumonia or they have a fall or something like that, that's obviously going to increase mortality risk. But we've got these patients who are being very lovingly cared for by, nursing facilities, by assisted living, by their, friends and family, that they can't maintain their own activities of daily living, but somebody's feeding them with a dropper. They're managing their personal hygiene, all these kinds of things. They can keep this person alive for a very long time. That doesn't mean that the illness has slowed down or that anything has changed. It's not the fault of the hospice that the patient didn't die within a certain time period. But that instills a lot of fear in hospice providers' hearts because they're worried about getting audited for things like that. So then talk, about what does the documentation look like? How are we continue to demonstrate that there's a progressive decline? And that's something that I think no fault of our hospice providers. There's not a lot of great training to explain how to really sort of articulate these almost like microscopic changes. That MAC has changed just a little bit. Instead of having 8 droppers of food that day, they took 6. I mean, it's really like these very small nuanced changes, but that do indicate that person is continuing to decline. So I think it's that in a lot of ways that dementia patients have kind of been left out, even though they're a huge proportion of hospice eligibility, hospice enrollment these days. It's just it's not very, I think, supportive for them.
Being in hospice, I think one of the ways that at least I try to protect my agency when it comes to scrutiny of LCDs is making sure that you have a hospice medical director that really understands those minute intricacies that, oftentimes, especially with startups or even, let's say cardiologist, physician, one, here's that hospice, you can make a lot of money, go in there. Well, you don't have the right medical director leading those things. It's going to be hard to justify, even if, like you said, it's not the hospice's fault one way or another, but you need that documentation and you need somebody leading you clinically that understands how to do it and is willing to defend it when called upon. I mean, regardless of all of our other positions, at the end of the day, that medical director is going to have to defend that CTI, right? So how are they from here to here still appropriate after 9 months of service? But I also think, hospice with this new guide program coming out, that they're taking an interest in dementia patients. But I feel like since I've started in hospice, like you said, it's most of the dementia patients are being taken away from hospice because the government is too afraid of long-term 6-year hospice stays that ruin the hospice model. But to your point, it seems like there needs to be more or an exception to the rule in some way. How do you?
I don't know the answer to that. I agree with you. I think there needs to be a different set of criteria for eligibility for dementia patients. I think the payment model eventually will change, especially with the Carvin. And I don't know what that's going to look like, but I do think that there should not be punitive measures to hospices if a person happens to exceed 180 days, as long as we can continue to demonstrate that there is a decline, and that based on your clinical judgment at that point in time, you would not be surprised if this patient dies in 6 months. That's fundamentally the question. I would not be surprised. The fact that somebody is taking fantastic care of their loved one and keeping them alive, that's a credit to the family and to the caregiver. That should not be a punitive action against the hospice.
And truthfully, that makes it easier for the hospice when the family's taking care of them. It makes it 10 times harder for the hospice when you go into a train wreck of a situation where the family is either undereducated or they just don't want to deal with the situation, like the 25% of people that live alone. It's like somebody knows that they're living alone. They just don't want to deal with it.
Yeah, and it's heartbreaking. And I think, again, I love that there's a focus on education and support to the to the clinical caregivers, helping them. I mean, I used to run a support group when I was working in assisted living, and that was a big discussion every single month. What is normal, what is not normal, what happens when they do this, or why did they do that? And helping take the burden and the guilt that they're not doing a good enough job away from these families. I think the psychological damage that guilt does to people when they're caring for folks is just unrecognized. And, especially when it comes to end of life decision making, and this is a different soapbox I'll get on, but the conversations around advanced care planning and what a person wants, what matters to them, and how they would want to live out their days if they were to be afflicted with a serious illness. You have to have those conversations early, and you have to have them often, and you have to, if you can, document them. But that changes as a person, ages and as their illnesses progress. So it's never a one and done conversation. And again, if your loved one is diagnosed with a dementia diagnosis, really need to have those conversations sooner than later, and what matters to you, how can we honor you and your legacy and make sure that you're living the way that you in your right mind would have wanted, and not, something that we're foisting on you because of our feelings around it.
Yeah, so Rory, I think, an interesting concept I was thinking while you were talking, not formulating my answer, but listening to you. I wonder from a financial perspective, if CMS is really going to compare the cost of care of hospice care for a dementia patient as opposed to the cost of care with this guide model, right? To see, because I was thinking it's kind of like CMS is filling in the cracks of what happens with these dementia patients, because it's terrible to go visit with the family of a patient that has moderate dementia, right? They're looking for hospice services. Maybe they've been referred, and you just look at them and go, there's nothing we can do for you. We don't have anything to offer. So I'm wondering if, this is the guide program is CMS's answer to that. And I'm interested in how they're going to manage that financial data that they have, and if there'll be some comparison down the road to see which is most cost effective.
I would love to see some of those retrospective analyses when the, what program is concluded. It's starting this July, so we're in 2024. It's going to run for 8 years. So what I think interesting about that time frame is that's roughly the amount of time a person from the time they're diagnosed with Alzheimer's to death. So I think that they're probably expecting to have some folks enrolled in the cohorts are pretty early on, like you said, early to moderate stage dementia. So it'll be the job of the actuaries to kind of figure out, okay, well, let's do these retrospective analyses and figure out, did we reduce hospitalization costs, at an average of $12,000 a pop in the last, year of life, and an average person has 6 hospitalizations, roughly that cost. Were we able to, with people enrolled in this model, which, as I said, without calling it palliative care, really looks like a palliative care delivery program, were we able to reduce the hospitalizations? Were we able to reduce the costs of medications? Was there earlier enrollment in hospice? And, all of those kinds of things that we know are the right things to do and the right outcomes for those patients. But like I said, it'll be the job of the actuaries to do that. So it'll be interesting. I'm optimistic. I think it's an innovative and novel way to provide support to the patient and family. And the other thing is, I think it's a novel and innovative way that palliative care providers can be reimbursed for all of the stuff that they do that currently there isn't an adequate reimbursement.
Well, and I believe when I was reading over this, and I've been a big proponent of talking more about social determinants of care, and this seems also to be a one step closer in merging both clinical data, body, vitals, whatever, with the social determinants that are also hugely impactful to somebody's outcomes. And it's just been hard for us to quantitatively define the social determinants. But I think what Zaundra was saying too, it's like, if we look at it from a financial piece, I wonder how many of the caregivers are going to have reduced healthcare spending because, again, we have given them more resources. So it's not even just the patient globally in that household or in the small community circling that household. There's probably also some reduction and some savings and some quality improvements.
I'm sure you're right. And I would love to see if there was a way that they could quantify that. I think that probably is a little more challenging, but it absolutely is a huge, player in that, and the idea of the guide model with creating these community organizations, these wraparound services, to your point, we need to connect this family with Meals on Wheels. Okay, great. Now we're addressing food insecurity. Oh, you know what? We need to connect them with either Uber or Lyft or, some low cost transportation service. So we can actually get them to the cardiologist so they can get their medications and make sure that their heart failure is being addressed, in addition to the dementia. All of those things that drive poor outcomes related to social drivers of health can be addressed, by these partnerships. And I think you're absolutely right, that it will improve the lives of those caregivers as well. Just having, somebody to call, somebody to ask questions of, and making sure that they know that somebody's looking out for them and helping them with resources. That's the one thing I think you cannot underscore the importance of the social workers on a palliative care and hospice team. But, in community-based palliative care in particular, the social workers are probably the hardest working group of individuals out there. They may see, 2 to 4 patients a day or less, but they spend hours on the phone connecting people to resources, finding the people the things that they need. And, especially in a community-based palliative care program, because they're not directly reimbursable through Medicare Part B fee-for-service billing, organizations don't have them. Unless they are, either have a philanthropic support or they have some other sort of payment model. It is one of the most valuable resources that sometimes our teams are missing because of the way that fee-for-service reimbursement is set up. And I think that's a travesty to those programs. And it's such a loss for those families who could really benefit from that. So I'm really, like I said, I just love the way that the model really encourages those partnerships. Working with PACE programs, for example. PACE and hospice enrolled patients are both excluded, but borrow from the model. Set your program up similar to how a PACE program might set it up. You don't have to reinvent the wheel. So I think that it'll be really interesting.
Yeah, I'd like to also see potentially down the road if these programs are also to look at dialysis patients as well. I don't believe dialysis patients get a hospice experience that is one that, that they're justified to get or that they earned. It's not the same, and could obviously use some redirection.
I'll admit I'm not as well versed in the kidney care choices demo, but I think that's ultimately what it's attempting to test. What are the outcomes when a person is still receiving dialysis, but also able to obtain the benefits of a holistic service like hospice? Like I said, I'm not an expert on it, and I should be, but I think that's part of what they're looking at.
What was that called? Kidney what?
Kidney care choices. KCC.
Nice. I'll have to look that one up too. Yeah. That's though. It seems like dementia and dialysis kind of sit outside of the hospice experience that we want to give, and it's always disappointing. Zaundra said it earlier. You go into the family and you can't give it to them because they don't qualify, or you go to the family and you go, hey, the only way you're going to get these services if you stop doing the one thing that's actually keeping you alive. That's a very difficult conversation to have.
You are preaching to the choir, John. I think one of the, at least for the pediatric population, the ACO, the Accountable Care Act that allowed for concurrent care for children, because parents can't be faced with that difficult choice of having to discontinue chemo or enroll their patient in hospice, their child in hospice. I have always said, I don't understand why that's any easier of a choice when I'm talking about my dad or my mom, or my grandmother. I don't want to have to discontinue something that might be creating symptom relief. You might not, but perhaps they need that radiation to shrink the tumor that's going to control their pain. Perhaps they do need that dialysis so that they're not overwhelmed with the types of symptoms you get when you have all of the problems that you have with end-stage renal disease. So that's not, it's being tested under the VBID hospice benefit design. Transitional concurrent care is included there in the flexible benefit opportunities, but it hasn't had a huge uptick as of the last the report that came out for the 2021-2022 data. Neither palliative care nor transitional concurrent care had huge numbers. Due in no small part, I'm sure, to the overly complex reporting requirements and who's going to pay for what and all those kinds of things. But the reality is, Medicare Care Choices, for example, did show that when you were allowed to have concurrent treatment with the hospice benefit, patients self-selected to discontinue those treatments when they were ready. And they were ready a lot sooner than people expected. So I think if you give people the option to say, let's try that chemo, let's try that dialysis, let's try this. And if you feel better, great. And if you don't, then, we're still here to support you. And patients don't feel good with chemo. They don't feel good with radiation. Dialysis eventually fails and patients start to feel crappy even with it. So, it was a proven approach that was sadly sunsetted in 2021. And, we still sort of keep our fingers crossed at NHPCO that maybe CMMI will look at a 2.0 version of that, and demo a community-based palliative care model. But, right now, I don't think CMMI has a huge appetite for a standalone CBPC demonstration, but, here's to hoping.
Fingers crossed. Roy, thank you so much. We're going to shift a little bit. I have Clay joining us. Clay, I don't see your video. I'm not sure if you could turn your camera on or not, but.
Can you hear me at least?
Yeah, we can hear you, Clay.
Well, that's weird. I gave it Axxess. Let me see if there's anything I can do to help that. Give me 1 second.
So just so everybody knows, Clay Hooten is from Axxess, and Rory, I am not sure if you're coming to Agile or not this year. I know you were one of the speakers last year, and Agile is last year was our initial conference that we had with Axxess, and so this will be our second year. We're expecting a really, really big turnout. It's going to be really exciting. And Clay, I've asked Clay to come on and just talk about a little bit about how folks can register, the types of speakers we're going to have, and that type of thing. So if Clay could maybe just kind of speak to that. The other thing I wanted to mention is next week, to follow up on Rory's presentation and Zaundra, we are going to have John McGuire, who will be speaking about the Zing Performance Program that actually has some really great opportunities for folks with cognitive decline to actually improve with increased plasticity. Neuroplasticity. Sorry. Thanks, Rory. And that will that's going to be a really, really good episode as well. So I would encourage everybody who's on today to listen to this follow-up, because a lot of things that Rory was talking about today will be impacted by what John has to say. There he is.
There he is.
Got it.
Well, I'll piggyback on your comment, Arlene. Agile was a great conference last year, so if folks have the opportunity to go to Dallas, I would encourage them to do so. It was a great experience.
Well, thank you.
Well, I got it fixed. So can I jump in now?
Yeah,
It's all yours, Clay.
Excellent. Well, thanks for having me. And again, sorry, my browser was blocking the webcam. So I apologize. So like was said, my name is Clay Hooten. I'm a senior director of marketing here at Axxess, and we are absolutely gearing up for Agile. We had our, just like Arlene mentioned, we had a really successful inaugural event last April here in the Dallas area. And we are gearing up to have an even more successful conference this year. It is April 21st to the 24th at the Irving Convention Center, which is just outside of Dallas, Texas. And just like was mentioned before, we are welcoming thought leaders from across the industry. We're going to have breakout sessions, educational sessions, CEUs, inspiring speakers, a party, and literally countless opportunities to connect and network with peers and friends. And that, I honestly, from my perspective, that was one of the most encouraging things, was to watch all of those connections that people got to share throughout the experience.
Yes. I heard people say that, in conferences, usually once you get past that second day, you're ready to go home. I heard people say, I don't want to go home. I don't want to leave. I want to stay.
Yeah.
I want to hear more. I want more.
Yeah.
Yeah.
That's what we hope for this year. And just a quick mention about the facility, the Irving Convention Center, compared to where we had it last year. And again, we had an amazing, beautiful venue last year, but the Irving Convention Center is inspiring and beautiful and really dynamic, really cool. And one thing that we've added this year is actually a recharge lounge. And so there is lots of hustle, there is lots of bustle, and we've carved out a little dedicated space just that is quiet and comfortable. We're going to have, infused water and comfortable seating and just a place to kind of disconnect for a bit, which is really, really encouraging. And so for anybody, again, who is interested, there's a lot of opportunities. There are sponsorship opportunities available. We've got a beautiful innovation showcase that's going to feature, of course, an opportunity to get to know our Axxess solutions from station to station. And then also many of our sponsors will have little tables there that they can, again, answer questions, entertain, demo, etc. And so we've got sponsorship opportunities available. And of course, tickets are for sale, and all of that can be found at axxess.com/agile. All of that registration information and details is up to date there, and that is really the central hub for all things Agile related. We are also very diligent about populating our LinkedIn channel, Facebook, Instagram with all of that detail, and to a certain extent, a little bit more detail. That's kind of where the fun, juicy details get to come out about education sessions, our breakouts, our keynote speakers, and on down the list. So we have lots of information out there if people want to find it, and we would welcome anybody. Again, the more the merrier. And again, the more voices, the more perspectives is what makes this successful, right? Because the aim here is to make it much more than just a user conference. Yeah, we're going to do that. We're going to cover those bases, but this is about collaboration and really shaping the future of care at home. That's been the mission from the beginning. So very exciting. Axxess.com/agile, April 21 through the 24th.
Thank you so much, Clay.
Yeah, of course.
Well, guys, we're just going to wrap up here. Rory, Zaundra, Clay, thank you so much for joining us today. We learned a lot.
Yeah, thanks a bunch, you guys. It was fun.
It was fun. Thank you.
we're looking forward to hear the statistics coming back from the CMS Guide program, and we'll keep you all updated as we get them. And I'm sure Rory will keep you updated as well. But until next time, next week, Zing Performance. We will be here Wednesday at 12 p.m. Central, 1 p.m. Eastern live. And of course, Arlene will be here, so you don't want to miss.
That's right.
We'll see y'all next week, guys. Thanks.
All right.
Thanks. Bye.
Thanks, everybody.
Bye.